Welcome to the Birth Squad podcast. If you're riding with the squad,
hey fam!
And if you're new,
welcome to the squad. We're your hosts, Dr. Ijama Okwando and Dr. Kanisha Thomas. We're two licensed obstetrician and gynecologists, as well as best friends.
The Birth Squad is a podcast for birthing individuals by two Black female physicians who use stories from real women to educate about pregnancy, birth experiences, reproductive health, and all things in between.
And while we hope that you love learning from our podcast, it is not intended to be a substitute for medical advice, diagnosis, or treatment. So please consult your healthcare provider for your specific care. And to learn more about us and about the podcast, please follow us on Instagram at The Birth Squad. And also check out our website, thebirthsquad.com.
Please keep in mind that some of our episodes may cover topics that could be triggering to some individuals. Listener discretion is advised.
Meet Dr. Lydi Martinez and Dr. Brittany Burton. They are the next badass birth experts who will share their stories and help the squad navigate through the complex and inspiring journey of pregnancy, labor, birth, and motherhood. In this episode, we are talking about pain management options in labor. During the interview, you may notice some medical terms or jargon, but don't worry, we got you. We have included definitions and explanations in the episode notes, so please listen up and enjoy their story. Hello, everyone. I am so excited today, as usual, to introduce wonderful guests. We have two anesthesiologists that are actually specially trained in obstetrics specifically. We have Dr. Martinez and Dr. Burton. Thank you so much for coming and welcome to the Birth Squad.
Thank you for having us.
Thank you for having us.
Yes, so do you mind both telling us about yourself and what was your path to anesthesia?
I did undergrad at UCLA. I'm originally from Los Angeles. Then from there, I kind of thought more public health, pursued a master's in public health at Johns Hopkins. And it was really there that I had great mentorship, and it put me on the path to academic medicine. And went to medical school in San Diego at UCSD. And then from there, residency at UCLA for anesthesiology. And I've always had an interest in maternal health. Black women in our community are the stronghold. So from that experience growing up, as well as my experiences at UCSD, that put me on a path to OB anesthesia.
Hi, everyone. My name is Lydi Martinez. I am also from Los Angeles, born in Nicaragua, but I grew up here in Angola, California. I always thought I wanted to go into medicine. When I got to medical school, I realized how much I loved working with my hands, working in the acute setting, working in the OR. I thought, I think anesthesia would be the perfect area. I got to UCLA where I did my anesthesia training. I went to UCSD for undergrad. After residency, when I decided to do anesthesia, I decided OB was the perfect field and where I get to, work with Latino communities specifically and Black communities where you see so much mortality and morbidity that's plagued our communities. And I feel like, being a woman of color, we were in the perfect opportunity to provide more meaningful care to our communities. And so I ended up doing my OB fellowship at Stanford, and now I'm back here in Los Angeles.
You both mentioned that you are specially trained in OB anesthesia. Can you just share with the listeners, what does that mean and what role do you play in the team?
Great question. From an OB anesthesiology standpoint, the goal when you do a fellowship is to develop the expertise to help manage high-risk pregnancies. So women that are over a certain age, women that have certain medical comorbidities, women who have had back surgeries, women that have significant scoliosis, etc. So our role is really, I think about more of a perioperative medicine role, where we evaluate the patients before labor and delivery. We get a sense of what their goals are, what they want, their birthing plan. We share with them what we can safely offer them, and we have a discussion with them, and we get a sense of what's the appropriate plan for the patient. And then on game day, when it's time for baby to come, we have a plan, and we're basically ready to go.
So, what exactly are the pain management options during labor? And then, what are the pros and cons of each of those methods?
In terms of pain management options during delivery, it will definitely be based out of what your institution offers, what the hospital offers. The most common are three types. So it's first is I'll go from the least invasive to the most invasive. So first is what we call the nitrous gas, kind of known as laughing gas that you may have heard used in the dentist office or during other short procedures. So essentially it's a gas that kind of relaxes you a little bit on the pain scale. I like to tell patients, if your pain is maybe at a level of 6, maybe it'll bring it down to a 5, maybe like a 1 point scale. So it's not the most effective, but for some people who want to try the least invasive option first, it's a great option. The only downside it is, I tell patients, an on and off medication. So as you're breathing it, you're holding the mask in, you get a little bit of relief, maybe during the contractions, and then you take it off, you stop breathing it, and then you don't have any of that benefit anymore. You have to do a lot of management with it. Some of the side effects are also nausea. Some people get a little bit discomfort, and, trying to manage something when they're already dealing with contraction pain. So it's not the most popular option, but it's there for, again, those who want to try something a little bit more less invasive. The other option we have is our pain medication that we give through an IV, so that little catheter placed in your vein. One of the most common forms of medication that we use is fentanyl, which is a strong medication, but it provides adequate pain relief during those strong contractions. Depending on the facility, sometimes though we do max you out at a certain dose because the higher in dosage we get, sometimes you get a little bit more sleepy, more tired, but we want to avoid that during your delivery process. We want to make sure your head is in the game, we're working all together, and we could take care of you as best possible. And then at certain points, it also starts affecting the baby, where baby starts getting sleepy, and we also want to avoid that to avoid any emergency C-section that we might have to do if the baby gets a little bit too sleepy and the heart tones go down. And the third, epidural, is essentially just a little catheter that goes in your back and is providing you medication. The goal would be to numb you from your belly down. So it's numbing down the pain of your contractions and you're comfortable during the procedure. And then those would be the top 3 most optimal options for pain control. However, we always tell patients, at the end of the day, sometimes it's your baby calling the shots or your body calling the shots. So, pregnancy could change from one second to the next. And sometimes we do have to do general anesthesia. That means putting you to sleep to get you through a C-section to make sure you and baby get through this procedure safely. And although it's a very rare likelihood, if you're overall healthy, that you will go through a C-section, it's always in the back end of our minds because as anesthesiologists, although we may have talked about plan A and B, we're always thinking about plan C, plan D, and any emergency scenario where we have to be on top of our game and make sure we get you and baby through this procedure safely.
Pain control options during labor is the most commonly discussed topic that we review during birth plan conversations.
Dr. Martinez does an amazing job of explaining the 3 most common options. Let's take a moment to review these in a little bit more detail.
The first one she mentions is nitrous gas, which is also known as laughing gas. This is a temporary option that is inhaled during a contraction to take the edge off your pain. Keep in mind that anything you inhale or get through your IV will affect the baby slightly. However, it is not offered at all hospitals or birthing centers, so make sure to ask your provider.
Speaking of IV anesthesia, this is another common option. They have a longer effect than nitrous gas, but will provide a very short period of pain relief. Often the dosing is every 1 to 2 hours. Additionally, we like to avoid giving this to you right when you're about to deliver because they can make the baby sleepy at the time of delivery. Some of the side effects of IV anesthesia include nausea and vomiting. So, as you can imagine, with this option or gas, you can't really walk around due to how unsteady they may make you on your feet.
Lastly is an epidural. This is the only option that does not affect the baby. They give complete coverage from the abdomen down, but it can lower your blood pressure. So the nurses will monitor you closely because, as you can imagine, your baby is happiest when your blood pressure is stable.
I just want to highlight general anesthesia briefly, which they also mentioned. This happens, like Dr. Martinez said, in very rare situations. Okay, now let's get back to Dr. Martinez and Dr. Burton. I could briefly talk about there are some people, for whatever reason, because of complications of their pregnancy, may not be able to qualify for an epidural. In addition to the nitrous oxide, is there any other alternatives for them?
The answer sort of depends on the institution. And I must say that the opinions that we're giving are opinions of our own. There is a lot of different institutional practices. And in addition, as Dr. Martinez mentioned, IV medication. So medication like fentanyl might be something that we can use. IM morphine is another option. It's longer acting than fentanyl.
Yeah, thank you for adding that. That's an important clarification. Hoping you can talk about the process of getting an epidural and what people can expect, and then kind of touch on the question that we get all the time is, can I have a walking epidural? I'm like, what does that mean? Can I turn the epidural up? Can I turn the epidural down?
So the traditional epidural, great for pain relief. So the downside of an epidural is that you in fact may have motor impairment. You may in fact have sensory impairment. And the combination of those two alone can significantly impair your ability to walk. So at a lot of practices, once that epidural is in place, you are now sort of confined to the bed. Although you may still be able to move your legs and you may feel like you can walk. From an institutional, from a safety standpoint, you're now considered a fall risk. So again, can't speak for every institution, but at a lot of institutions, once a traditional epidural is placed, you will be in the bed. You'll have a Foley place afterwards because now that you're in the bed, you will not be getting up to walk to the bathroom. Now, a walking epidural is this idea of having an epidural in place and still maintaining that ability to walk. There is some data to show that maintaining the ability to walk improves and helps the delivery process. With that being said, placement of a walking epidural is very similar to placement of a traditional epidural. So we clean the back, we numb the back up, we prepare the back for the procedure, and we place that catheter that Dr. Martinez was referring to. And that catheter stays in place. The difference is the type of medication the anesthesiologist will use. Okay. There are different options. You can use primarily local anesthetics. You can use primarily opioids. And the idea is the concentration and the type of medications will differ when you are placing and offering a walking epidural compared to placement of a traditional epidural. I will say in most institutions, when a walking epidural is placed, there needs to be a 1-to-1 nursing ratio. So one nurse for that patient, because anytime that patient now wants to walk, there needs to be a motor assessment to make sure you still have the ability to walk. If there is no motor assessment and you do not have the ability to walk, that is now a fall risk. So a motor assessment by the nurse, and the nurse needs to also be with you as you walk around. I should also say that walking epidurals are amazing, but oftentimes there is inadequate pain relief. Why? Because the concentrations and the formulations of the medications you use are very different than your standard, more traditional epidural. And I would say in my experience, there's roughly a 100% conversion rate where a walking epidural is offered. And at some point during that birthing process, as those contractions become more frequent, women prefer the standard, more traditional epidural. But it is something that many places can offer. But again, there's a lot of institutional differences in terms of how comfortable they are offering a walking epidural because of the protocols, the nursing ratio, etc.
Okay, let's quickly talk about a walking epidural.
Yes, a very good topic. The type of epidurals offered depend on the hospital and the anesthesia protocol. Many institutions don't have the ability to offer walking epidurals, and a lot of physicians don't feel comfortable having patients walking around when they are that unstable.
I often tell patients that our nerves are like electricity. Everyone is wired differently. So, some will be able to move their legs and still have amazing pain control. Others will be completely numb and unable to move their legs at all.
Exactly, but it's also important to keep in mind that the perineum or the vaginal canal has a different nerve innervation, meaning that when the baby is crowning, you likely will still feel the ring of fire. Sorry, y'all.
Now let's hear more from Dr. Martinez and Dr. Burton.
What are the difference between spinal anesthetic and an epidural? How do they individually affect pain relief? When is one used? When is the other one used?
So in terms of an epidural versus a spinal, so the way I think about it is typically, okay, what are we doing? Are we laboring for vaginal delivery, or are we going to a C-section? So an epidural is great because doing that procedure, you're leaving a catheter in place, which is a thin, flexible wire, and you are delivering. You're connected to an infusion bag, and that infusion of medication is going through that catheter into the epidural space, bathing those nerves and providing effective pain relief. So there's a catheter left in place. So in theory, you will have pain relief as long as you're receiving that medication, because you get a constant amount of medication per hour. Okay, but with the spinal anesthetic, there's a procedure that's done. That procedure is very similar to placing an epidural, with one exception. Well, with a couple, but the most important one is you do not have placement of a catheter with spinal anesthesia. So basically, there's just a single dose of medication that is delivered into the space around the spinal cord that provides pain relief for as long as the medication lasts. So what that means is that if the medication lasts 2 hours, you've got pain control for 2 hours. Now you can imagine that may not be appropriate for laboring, right? Because we know that the laboring process can be very long, much longer than 2 hours. So you can quickly see how the procedures we offered are tailored to the birthing plan. So typically, spinal anesthesia is more appropriate for a cesarean delivery, more appropriate for an elective cesarean delivery where emergencies are not of concern, because most C-sections can be done in under 2 hours, most, not all. And then you can imagine that an epidural is going to be more useful, more impactful in the laboring process, because you will need pain control far beyond the 2 hour period.
I'm gonna ask you guys a question. I'm sure it's like opinion related, right? So go ahead and you can say what your opinion is. But a lot of times people will also ask me, when's the last opportunity I have to get an epidural, right? I'm 10 centimeters. Can I still get an epidural? And then also, if you could answer, how are they safe? You mentioned epidural spinal. Is that safe for the baby?
Yeah, well, I'll say from the get-go, all the medications we use for our patients are safe for mother and for baby. There are at points where the dosing of the medication, maybe it gets you a little bit too sleepy, so maybe it gets baby a little bit too sleepy. And that's how, when we talked about earlier, the heart tones of the baby start to go down. And so we try to prevent that by, again, your anesthesiologist is in the room as we're giving the medication, and we're monitoring you the first few minutes after the procedure to make sure you and baby tolerated the procedure well. I usually like to tell my patients that you could get the epidural at any point, but what I like to remind my patients is that the procedure is still a procedure, and where we had to get you into a seated position, bent over, so we could stretch out your back. The way in which you stretch out your backs is so we could see your bones in the back and adjust where exactly we're going to put that epidural catheter. So the way we do the procedure is we numb your skin, and then we put a little bit with a little injection medication. We numb your skin, and then you're just going to feel pressure at that point. We're going to use a different needle to get to that point where we're going to infuse the catheter with the medication that's going to go around your nerves. So that procedure requires you to be very still. It's a very, intricate portion of your back. Your nerves are back there. We don't want to or injure anything. So we want you to be as still as possible during that procedure. So some patients will come in and say, well, I have a lot of anxiety. I have no pain tolerance, so I want it as early as possible. That's completely fine. We'll talk to you and your obstetrics team to ensure it's a safe alternative. that we could work with you around it. However, there's some other patients who say, well, I want to see maybe if I could try natural birth or see if I could extend or delay my epidural as much as possible. And, at the same time, same as our other patient, we'll still work with you through it. But the only thing we like to remind patients is that for the procedure, you have to be still as possible. So we don't want you to ask for it when you're at 9 out of 10 pain and you're like, thriving over your bed, moving around. It just makes the procedure a lot more complicated for us. And of course, we want to make this procedure as safe as possible. So I'd like to tell patients don't wait too long. And at the same time, remember, we sometimes have maybe 10 patients laboring on the floor, and there could be an emergency C-section called where the anesthesiologist is the only one on the floor and gets pulled away. So if you ask for that epidural when you're at 8 out of 9, 10, and we have to wait for that C-section that takes an hour long, you'll unfortunately be waiting there for that epidural for an hour. And we don't want you to be suffering through all that time period. So whatever point you feel like, okay, my contractions are getting a little bit stronger, 6 out of 10, 7 out of 10 pain, let us know as soon as possible, because sometimes we do try to get the epidural placed in between your contractions. We're skilled in that way. But again, it still sometimes could take us the procedure less than 5 minutes. Sometimes it could take us 20 minutes. We just never know what we'll encounter once we're back there.
And then also to piggyback off of Dr. Martinez, I basically say something very similar. I tell my patients, whenever you want the epidural, we can place it. However, the extremes are going to be challenging. So if you're 10 centimeters, crowning, feeling like you have that urge to push, it's going to be very, very challenging for you to get in the optimal position for us to place it. So that's one extreme. The other extreme is we have a fair number of women that come in for an induction, right? Induction of labor. So in that case, some women are very afraid, rightfully so, of experiencing any pain. So I've had it before where women want the epidural before the induction process starts. And while we can offer it, we know that our epidural is working when we treat the pain that you're having. Okay. I'll say this, that epidurals work very well, I would say 80 to maybe 90% of the time. There is that fraction of time that despite our best efforts, despite what we would consider a beautiful placement, it may not work the way and give us the adequate pain control that we want. So with that being said, it is helpful when I know for us it's helpful when you're in pain, but it's helpful when we have some contraction, some related pain, so that when the epidural is placed and you no longer have that pain after we start those medications, we are pretty confident that that epidural works well. So in short, I just tell my patients, barring the extreme, any time in between, you can ask and we're happy to come by and place it.
We tell our patients exactly the same thing. There is no set time to get an epidural.
If you have severe anxiety or are getting an induction of labor but don't want to feel the pain, then by all means, get an epidural. You want to see how far you can get without any pain medications? Again, we are more than happy to discuss alternative pain management options.
Now let's talk about that old philosophy that said getting an epidural will stall your labor or hinder you from getting a vaginal delivery. That is completely untrue.
Exactly, Ajama. We have experienced the situation where someone is in spontaneous active labor, meaning they're greater than 6 centimeters, and gets an epidural, and then we see those contractions start to space. Conversely, we have seen when a patient is 3 centimeters make change from 5 to 6 after they get an epidural, because in that situation, they are able to relax and allow their body to work with the contractions instead of in opposition.
So, moral of the story, every patient and situation is different. Try not to overthink it and let us help you accomplish your goal, however that might be. We are familiar with the effects of an epidural on labor and will counsel you on your options to manage each and every unique situation. Well, let's get back to our experts who are going to share information about eating around the time of epidural. At different hospitals that I've worked at, there's been different things that I've heard about the recommendations for avoiding eating, right? How many hours before an epidural is placed can people still eat? Are people allowed to eat while they have after they have an epidural placed? Can you even just explain why this whole eating thing is even up for discussion in relation to epidurals? And then what type of risk may it pose to women if they're like, maybe having a big meal right before receiving this form of pain relief?
That's a great question. And this is kind of gets at, what you call NPO, nothing by mouth, NPO status in medicine in general. But the idea behind being NPO is that there are some studies to show, these are early studies to show an increase in maternal death due to aspiration. So aspiration is when we vomit and the contents of that vomit goes into our lungs. The content is acidic, so it causes damage to the lungs. So there are early studies to show that if that were to happen, it increases the risk of maternal death. In addition, there are normal physiological changes in pregnancy. One of those is that during the laboring process, gastric emptying may be impaired. What that means is that during the laboring process, you can imagine there may be some nausea because of the medications, the anxiety, and the pain. There may be some vomiting. You may be receiving medications that increase the risk of nausea but are intended for pain. And if you then have a full stomach of Chick-fil-A or McDonald's, you can imagine how that can be a source of complications. So in short, this idea of nothing by mouth was born out of the studies to show if you have a full stomach during this laboring process where there's a lot happening, your risk of vomiting is increased. Your risk of that vomit going into your lungs is also increased. So practice varies across hospitals. Where I practice, we typically avoid heavy meals once the epidural is placed. Okay, but ice chips and water are okay.
I want to kind of shift gears a little bit and talk about women who might be hesitant about getting pain medication during labor. Maybe they've heard, oh, someone got an epidural and they have back pain like forever afterwards, or they hear about like a spinal headache. Are there any things that you've seen, like alternative or complementary therapies that you've seen people use in your practice to manage pain? And then additionally, what do you tell people who have those concerns about the back pain and the headache?
We like to tell patients that, like we mentioned earlier, you're coming with your birth plan for some patients, and we want to adhere to it as much as possible up to the point where it's safe for you and baby.
Massages, candles, presence of a doula. There are a few things that we've seen that may help women. But by nature, we're anesthesiologists and we work with our hands. So neuraxial anesthesia is always what we have to offer the patients. And I find that patients that want to avoid any significant interventions with respect to anesthesiology normally have a birth plan, oftentimes have a doula. They've been working with that doula somewhere since like maybe the second trimester. They also have a fair amount of family support. Partner is in there rubbing their back through massages, relaxing music, candles. So there is an entire experience that I've seen work very well for patients that are incredibly motivated. And I say motivated because working through those contractions is quite the task. So if patients are motivated, I've seen those approaches work pretty well.
As you can see, even anesthesiologists acknowledge the importance of support in labor, whether that is through a doula or a family member.
Oftentimes, people think hospital birth means medical intervention. But if your plan is to have an unmedicated birth, then our goal is to help you achieve that. Talk to your provider and see if your hospital has access to a tub or water births or a shower to help with pain relief.
Now let's see what information Drs. Martinez and Burton want to leave us with. What do you do when someone comes with those concerns because they heard a friend had back pain forever after their epidural, or a friend had a spinal headache? Can you explain a spinal headache and then kind of talk about your counseling around that?
But in terms of the complications from an epidural, so anytime you use a needle, there is obviously a risk of discomfort. There is a risk of infection. That risk, based on some data, is about 1 in 60 to 70,000, so fairly infrequent. There's a risk of nerve injury, not necessarily spinal cord injury because we place the epidural pretty low. I don't want to get into the weeds here, but I'll say the spinal cord ends at about L1, L2 in most people. We place the epidural below that. So we're not necessarily touching the spinal cord, but there still are nerves in that area. So I'll say the risk of significant nerve damage is about 1 in 40,000. So overall, again, we see pretty low in terms of those complications. But you bring up a headache, and a headache roughly is about 1%. Okay, so I would say of the complications, a headache is what we call a spinal headache. A headache is probably the most common. The most important thing I'll say right now is that it is not life-threatening. So what is a spinal headache? So it's a very characteristic headache. It's not like your typical migraine. It is a headache that is worse when you sit up and you walk around. Okay. So when you find that you're engaging with the baby, but you have this excruciating headache that just won't go away, but when you're laying down, it's all of a sudden magically gone, that is a headache that may be associated with our anesthesia procedure. If you do have that headache, oftentimes it will appear within 3 days of your neuraxial anesthesia, your epidural placement. If you elect to not have what's called an epidural blood patch, which is a procedure to help alleviate that headache. If you elect to not have that, I would say in the vast majority of patients, the headache will resolve within a couple weeks, but there still are some patients where the headache does not resolve and an epidural blood patch is a good option. An epidural blood patch is another procedure we do similar to placement of an epidural. We take some of your blood, we put it into that space, and it basically helps to patch up that area and decrease those symptoms. So basically, I think having an informed discussion with the patient, getting a sense of what their concerns are, giving them the honest, true numbers in terms of what they are most likely to experience in terms of complications. I think that bodes very well, and I think people get a lot out of clear and honest transparency. And for me, that has worked pretty well in my practice, and that's something that I make sure I do with each and every patient.
The question about permanent back pain or long-term back pain, that's actually a question I get a lot from my Latino patients. And so I like to remind patients, when we're doing the epidural, we numb your skin first with a little injection. And, with just any needle going into your body, like when you get a flu shot, when you get injections elsewhere, you're going to be sore in your arm for like a week or so. And so similarly, we're going through your skin and muscle in the back. And so we anticipate that area where we did the procedure to maybe just have a little bit of dullness of pain, which isn't uncommon. I would also like to remind patients that, when you're going through the birthing process, your baby's head is kind of lodged into your back where your nerves going down to your legs are and around your back are. And so, in some women, birth could be as quick as 3 pushes and baby is out. But in other women, sometimes baby's head is lodged there for a few hours. And if you have an epidural, you might be numbed up to where you're not sensing that kind of like nerve irritation that your baby's head is giving you. It might appear maybe a day after when when the anesthetic medication from the epidural is completely out of your system. You're like, oh, now I have this numbness in my leg that wasn't there before. And that could be from the irritation of the baby's head that was like pressing on your nerves. But it's nothing that we don't have therapies for. We always like to advocate for physical therapy.
Okay, so I wanted to pivot a little bit now. I'm not sure if the two of you knew, but I actually did an OB anesthesia rotation while I was in my residency. And I already thought this, but really doing that experience made me realize even more so that anesthesiologists are like the silent superheroes of the whole like OB experience and also for our surgeries. There is a very specific role that anesthesiologists get to have, especially during a C-section and especially during like emergencies. So can you just elaborate a little bit from your experience? What role do the anesthesiologists play to ensure like the well-being of both, mom and baby, especially during these like emergency situations?
So the role that we play. So say we come into the room, you want an epidural, we place the epidural, you've got great pain pain control, you have now what's called labor analgesia. So you have good pain control. God forbid, your obstetrician gynecologist determines and declares that, hey, we need to have an emergency C-section. We now have to transition from labor analgesia, labor pain relief, to what we call surgical anesthesia, right? Because this is now a surgery you're going to have. So I think of our goal at the moment twofold. So to make sure you have enough pain medication on board to be able to tolerate surgery, and then also to keep you stable. So what that means is keeping all of your vital signs within their baseline normal ranges. So your blood pressure, your heart rate, your oxygen status, etc. So our goal is to ensure that the obstetrician gynecologist can operate, you can tolerate the operation because you have good pain control, and that your vital signs are stable throughout the entire procedure. That's one emergent situation where an anesthesiologist and OB anesthesiologist are incredibly crucial. There are a few others like postpartum hemorrhage, retained products, and a few others. I won't go into the weeds too much, but I would say by far and large, us being present for an emergency C-section is number one. You definitely want an anesthesiologist in the room at that time.
And I like to remind patients also, just like you go to your primary care doctor to manage your hypertension, your diabetes, your asthma, when you're in the operating room, we're your primary care provider for that surgery. So we're managing your diabetes, your asthma, patients who are developing preeclampsia during delivery or during the laboring process. We're talking closely to the surgeons. They're the ones who are in the weeds of the surgery. So if they're seeing a lot of bleeding that's starting to start up, we're already thinking, okay, we need to get blood in the room. We need to get access to ensure we could get that blood into you safely during the process. And we're also ensuring that our medications aren't interacting with baby. We have the baby doctors in the room as well. We're talking with them, ensuring baby is getting through the procedure fine. So, in addition to managing your pain, we're having to manage all the comorbidities associated throughout the labor process. And so, although we're very busy, we're right there. Our head is literally in the game. We're right next to you as a patient. So our job is to not only reassure you, but also reassure our surgeon that things are stable on the other front, because they're so focused on the surgery and baby that it's only left to us to manage everything else.
And in addition, I'll say it's wonderful when we get to be your family medicine or primary care provider, but in unfortunate situations where we have to be your ICU provider because there's an unfortunate cardiac arrest, blood clot in the lungs, a blood clot in the heart, any significant complications that causes your heart to stop, we are now your ICU provider, and we do our best to manage and run that situation and make sure that the outcome is the best outcome for you and for the family.
Such a great point. It resonates so much with us because when you said that, I'm literally going through all the emergencies I've had where in my head where I'm like so reassured when the anesthesiologist walks through the door, or you're like, call the anesthesiologist. Even in our training, when we talk about a hemorrhage, there's like an algorithm where if you're getting to a certain level of medication, the instruction is to notify the anesthesiologist of what's going on. So I think people just don't realize how much we work hand in hand with you, and how much we rely on each other, and how much communication happens between us.
The other thing I wanted to say is, like, in addition to all of that medical management, there's also such of like the human aspect of it, right? Because the surgeon has that big blue drape in between them and the patient. So there's not much communication. If there is, it's just like this, faceless voice over the curtain. But you two, as anesthesiologists, are actually like right next to the patient, can really connect. You're often the ones giving that reassurance. You're sometimes the only eyes they actually get to see. And then, when I see these patients postpartum, they're asking about, oh, who was that anesthesiologist? I don't remember their name, but they really helped me through that moment. So I just want to just acknowledge how much of an important role you all play in those situations.
That's wonderful. And I'm so happy to hear that they're asking about the anesthesiologist because the situations are often very critical and we are managing the critical nature of the situation and managing the expectations, the emotions, the fears, holding hands at the same time, making sure the partner is okay. So there's a lot that's happening and we don't always get a sense of how the patient feels about the experience. So it's wonderful to know that oftentimes they're asking, who is that anesthesiologist?
I will say, don't get me wrong, though. I feel like it's also a good thing sometimes when you don't know the anesthesiologist because that means you had a very safe labor. Everything went great. You and baby did fine. So it's when we start to get to know each other a little bit better that's like, okay, but don't worry. We're still in the game with you. And I definitely like to take advantage of this opportunity to also thank our nurses who played just as big as a role during the whole cesarean process and laboring process. I know when things have gotten heated, emergencies happen in the OR. There are extra hands, as anesthesiology, we have to take care of your airway in an emergency setting, intubate you, place larger IVs, ensure blood is going into you as fast as possible. And those nurses are really our right hands because team player kind of game. And I appreciate our surgeons just as much as our nurses.
Well, thank you so much for everything you had to share. Something else that you want to share with the Birth Squad?
Thank you so much for having us. We really appreciate it. The questions were very comprehensive, and I think we touched on some very important points. Questions are good places to start. But if you all have any questions, you can contact the Birth Squad, and we are happy to engage in more discussions and go from there.
Thank you guys again for having us. And again, just like to remind everybody, we know this is always a critical time period in a woman's life. We want to respect your choices. Make sure this is just as a joyous, monumentous time for you. So we want to make sure that always have those open conversations with your obstetrician and your anesthesiologist. At the end of the day, we just want to see you and your babies going home happy and healthy. So we're here for you 24/7 and reach out to us if you guys have any questions.
Well, thank you so much. That's the wrap of this episode of The Birth Squad.
Thank you so much for joining us this week. We are going to continue sharing stories from more badass birth warriors because at the end of the day, you are the experts of your experience. And we want to highlight you and your bold, brave, and beautiful journey to motherhood.
And we want to hear from you. Tell us about what topics you'd like to hear more about. Hit us up on Instagram at The Birth Squad. And check out our website, thebirthsquad.com.
Most importantly, be sure to share this episode with your squad.
Until next time, I'm Dr. Ijama Okwandu.
And I'm Dr. Kamisha Thomas.
Peace, love, and solidarity from the Birth Squad.